Hey everyone, it's Wadi again. We're going to be doing another video utilizing the SP robotic platform for transanal minimally invasive surgery. So in this case, I had a 45-year-old male who presented with rectal bleeding. He was scoped and we found this distal polypoid lesion in the lower portion of the rectum. Just to review the setup, similar to my last video, you can do this either in dorsal lithotomy or prone jackknife positioning. I like to use the fenestrated bipolar and the monopolar scissors for my dissection, as well as my exposure, and then a needle driver to help with the closure, and then a Rosie to help minimize any fog or smoke. And you want to use a small access port for this. Pneumoperitoneum, ideally with the air seal, you could set the pressures 12 to 15, but more lately I've been doing lower pressures and you could get away with that as well. So in my left hand I have the bipolar, in my right hand I have the scissors, and you see the Rosie just at the bottom of the screen. For the first part of the case, you really want to score the borders of your resection. This will help guide you during the case. Now, interestingly enough, even with the Rosie present, likely due to the very low nature of this lesion, I was having issues in the beginning with just a Rosie kind of popping in and getting a little bit stuck on the lesion, number one, and also with the smoke not evacuating properly. So what you'll see here in a second is I pull back and I introduce a third instrument. This will hold onto the Rosie through that suture tie off to the side and help better position it. So here I go, I'm bringing the Rosie out. I'm bringing in a needle driver to help hold this. Then I'm able to go back in and proceed with the case. And what I'm trying to do here is just very slowly and meticulously dissect circumferentially, trying to stay in the same plane, making sure I'm not leaving any residual polypoid tissue behind in my resection. Another option here is to also place a stay stitch, either proximal or distal to the lesion, and what you can do is use that as an anchor to help with an additional exposure, and I've seen that done as well. This lesion wasn't overtly large, and I didn't feel the need to do that for this case, but it's certainly an option. So I'm about to finish amputating the specimen. It's very important once you're done with that to try to maintain proper orientation, especially if you're worried about cancer. So what I'll do here is either bring the specimen out to the globe, or I'll have the laparoscopic bedside assist come in and grab it, and then I'll have it properly oriented on the back table, either in a cork board or a paraform block. I always try to close the wound when I can. I like to use a V-lock suture for this. You could also use a Stratafix or a Vicryl. Of course, always remember to close it transversely so you don't narrow luminal patency. So I typically close the defect in 1 to 2 layers. The approach is very similar to if I was using a multi-pore like an XI or DV5. I think the biggest difference is a couple factors. Number one, less external and internal collisions, better ergonomics of using the SP arms due to that ability for internal elbow rotation. Then also a smaller platform for docking, which I think leads to less external trauma as well. And there it is. Thank you so much for watching. Hopefully this was helpful to some of you. In my next couple of posts, I'll be posting some of my transabdominal surgeries. If you had any questions about setup or troubleshooting, please feel free to reach out.